Margaret woke up on a Tuesday morning and couldn't see her husband's face. Just 12 hours earlier, she'd driven herself to the pharmacy, read the medication labels without glasses, and cooked dinner while watching her favorite cooking show. By sunrise, the world had gone dark. Not blurry, not dim, black. The emergency room doctor asked her the same question I would ask 3 days later when she landed in my clinic. "Did you take your insulin last night?" She nodded. "Double dose," she whispered. My sugar was high after dinner, so I corrected it. That's when I knew exactly what had stolen her vision. And it wasn't what you think. Here's what nobody tells you. The most dangerous thing a diabetic can do isn't skipping insulin. It's taking too much, too fast. Stay with me. Because what happened to Margaret's eyes is happening right now in bodies across the world, and the medical advice you're following might be setting you up for the same catastrophe. I'm a cardiothoracic surgeon. I've held beating hearts in my hands for over 30 years, performed more than 2,000 surgeries, and spent enough time in operating rooms to know that what happens in the heart affects everything else, especially the eyes. But my education about diabetic blindness didn't come from textbooks. It came from Margaret, from James, who lost his left eye 2 years after his diagnosis, from Patricia, who went from 20/20 vision to legally blind in 16 months. They all made the same mistake. The medical system told them to control their blood sugar aggressively. Nobody told them that the speed of that control could destroy the delicate blood vessels in their retinas. I've watched colleagues hand patients insulin pens and say, "Get that A1C down," without explaining that dropping blood sugar too quickly is like slamming the brakes on a speeding car. The passenger, in this case your retina, goes through the windshield. After 60, your body doesn't bounce back from metabolic shocks the way it used to. Your blood vessels have been dealing with elevated glucose for years, maybe decades. They've adapted. They've remodeled. The tiny capillaries in your retina, thinner than a human hair, have built fragile workarounds to survive in a high-sugar environment. These vessels have lost their elasticity. The smooth muscle cells in their walls have been replaced with collagen, making them stiff and brittle. Your body's natural repair mechanisms, the ones that patched up damage when you were 40, have slowed to a crawl. The cells that line your blood vessels, the endothelial cells, don't regenerate as quickly. When damage happens, it compounds instead of healing. Think of it like a river that's been flooding for 20 years. The banks have eroded, new channels have formed, and the ecosystem has adjusted to the water level. The fish have adapted to murky water. The plants have grown roots that tolerate submersion. Now imagine draining that river in 48 hours. Everything collapses. The fish die from oxygen shock. The exposed banks crumble. The plants wither. That's what happens to your retinal blood vessels when you crash your blood sugar too fast. The National Eye Institute published data showing that diabetics who drop their A1C by more than 2 points in less than 6 months have a 74% higher risk of severe vision loss compared to those who lower it gradually. 74%. That's not a small difference. That's the difference between reading a book and never seeing your grandchildren's faces again. It's the difference between independence and needing someone to tell you what's on the stove because you can't see if the burner is on. Here's the first thing diabetics must stop doing immediately: aggressive blood sugar correction without medical supervision. Margaret's story didn't start the night she went blind. It started 6 weeks earlier when her new doctor told her, "Your A1C is 9.2. We need to get that under 7 immediately." She left with a new insulin regimen, higher doses, and instructions to check her blood sugar 4 times daily. She followed orders perfectly. Too perfectly. Within a month, her A1C dropped to 6.8. Her doctor celebrated. Her retinas hemorrhaged. The mechanism is called hypoglycemia-induced retinopathy progression, and it works like this. When you've had high blood sugar for years, your retinal blood vessels become leaky and weak. They develop microaneurysms, tiny balloons of damaged vessel wall. These balloons are filled with high glucose blood, and they're under pressure. The vessel walls have stretched and thinned. They're holding together through sheer stubbornness at this point. When you suddenly drop your blood sugar, you create a glucose gradient. The blood inside those microaneurysms is still high sugar, but the blood outside has normalized. That gradient pulls fluid out of the vessels through osmosis, like water moving through a membrane to balance salt concentrations. The microaneurysms can't handle the osmotic pressure shift. They rupture. Blood spills into your vitreous, the clear gel inside your eye. If you're over 60, your vitreous is already breaking down from age, becoming more liquid, less gel-like. The hemorrhage spreads faster through liquid than gel, like ink in water versus ink in honey. By morning, you can't see. The blood has diffused throughout your eye cavity, blocking light from reaching your retina like a curtain pulled across a window. Write that down. The danger isn't high blood sugar alone. It's the speed of the fix. Margaret needed 3 emergency laser surgeries to seal the bleeding vessels. Each surgery involved hundreds of laser burns to her peripheral retina, creating scar tissue that stops abnormal vessel growth. She regained partial vision in her right eye, enough to see shapes and movement. Her left eye never recovered. The damage was too extensive, the scarring too severe. I asked her what she wished someone had told her. She said, that slow and steady wasn't just for weight loss, that my eyes needed time to adjust just like the rest of me. The second thing you must stop, taking extra insulin to correct a high reading without understanding why it's high. James learned this lesson after losing his eye. He'd check his blood sugar before bed, C220, and inject extra rapid-acting insulin. He did this 3, maybe 4 times a week for months. What he didn't know was that his blood sugar was spiking because of stress hormones, not food. His body was releasing cortisol and adrenaline at night, common in diabetics over 65. It's called dawn phenomenon, or nocturnal hyperglycemia, and it happens because your liver releases stored glucose in the early morning hours. Your body thinks it needs fuel to wake up. In non-diabetics, insulin rises to match it. In diabetics, that insulin response is broken. The extra insulin James was injecting didn't address the cause. It just created wild blood sugar swings. He'd inject at 10 p.m. when his sugar was 220. By 2 a.m., when the stress hormones faded and the insulin peaked, his blood sugar would crash to 60. His body would panic, dump more stress hormones to raise it, and by 6 a.m., he'd be back at 200. Up, down, up, down. His retinal vessels couldn't handle the roller coaster. The mechanism here is called glycemic variability, and it's more damaging than sustained high blood sugar. Imagine your retinal blood vessels as garden hoses. Steady high pressure will damage them over time, sure. The hose will develop weak spots, maybe a slow leak. But rapidly fluctuating pressure, high then low, then high again, causes them to crack and burst much faster. The vessel walls are constantly expanding and contracting, stretching and relaxing. The cellular junctions that hold the vessel lining together get pulled apart. Proteins that normally keep the vessel wall strong get degraded faster than your body can replace them. A study from the Joslin Diabetes Center tracked 500 diabetics over 3 years. Those with high glycemic variability, meaning their blood sugar swung more than 100 points regularly, had double the rate of proliferative retinopathy compared to those with stable, even if elevated readings, double. James's blood sugar logs looked like a seismograph during an earthquake. Spikes and valleys, no flat ground anywhere. When I showed him the pattern, he broke down. I thought I was being responsible, he said. I thought catching the highs before bed meant I was being proactive. His endocrinologist had never mentioned variability, never asked to see his log patterns, just told him to keep his numbers in range. The specific fix: stop correcting bedtime highs with rapid insulin unless you've confirmed the cause with your doctor. If your blood sugar is over 200 before bed and you haven't eaten in 3 hours, it's hormonal, not dietary. Adding insulin creates a dangerous drop around 2 a.m. when those hormones fade. Instead, talk to your doctor about adjusting your basal insulin, the long-acting background insulin, or adding medication that targets dawn phenomenon. Metformin can help reduce the liver's glucose dump. SGLT2 inhibitors can help your kidneys clear excess glucose. Your eyes can't survive the swings. They need stability more than they need perfect numbers. Here's what nobody tells you about the third mistake, and this is where Margaret's story gets worse before the cliffhanger. She was also taking high-dose vitamin supplements, specifically vitamin E at 800 IU daily and fish oil at 3,000 millimol. Her naturopath told her these would protect her heart and eyes. They did the opposite. High-dose vitamin E is a blood thinner. So is fish oil at doses above 2,000 millimoles. Margaret was essentially on 3 blood thinners: vitamin E, fish oil, and the daily aspirin her cardiologist prescribed. When her retinal vessels started leaking from the rapid blood sugar drop, her blood couldn't clot properly. A small hemorrhage became a massive one. The mechanism is straightforward but rarely explained. Your retinal blood vessels are the smallest in your body. When they're damaged, your body tries to form tiny clots to seal the leaks, like patching pinholes in a water pipe. Blood thinners prevent those patches from forming. The leaks become floods. A Stanford ophthalmology study found that diabetics taking multiple blood thinners had 3 times the risk of vitreous hemorrhage requiring surgery compared to those on standard aspirin alone. 3 times. I've seen this pattern repeat in at least 20 patients. They're taking baby aspirin because their cardiologist said so. Fair enough. Then they add vitamin E because the internet said it prevents heart disease. It doesn't, by the way. Meta-analyses have debunked that claim. Then they add fish oil because Dr. Oz or some wellness influencer said it's good for inflammation. At therapeutic doses under medical supervision, maybe. At mega doses from Costco, you're creating a bleeding risk. When I asked Margaret's naturopath why he recommended 800 IU of vitamin E, he said, because more is better. That sentence should be criminal. But before I tell you how Margaret's story ends, I need you to understand something else. Something that connects all 5 of these mistakes. The fourth thing, diabetics must stop immediately, ignoring blurry vision because it comes and goes. So Patricia waited 9 months. 9 months of intermittent blurry vision that would clear up after a few hours or a day. She thought it was just tired eyes, aging, maybe needing new glasses. By the time she saw an ophthalmologist, she had advanced proliferative diabetic retinopathy in both eyes. The blurry episodes were warning signs, small hemorrhages that her body temporarily cleared, only for new ones to form. Each episode caused permanent damage she couldn't feel. The mechanism is insidious. When blood leaks into your vitreous, it blocks light from reaching your retina. Your vision blurs. Over hours or days, your body's cleanup cells, called macrophages, start breaking down the blood. Vision improves. You think the problem solved itself. It didn't. The underlying vessel damage remains. The microaneurysms are still there. The next spike or drop in blood sugar causes another leak. Bigger this time. More macrophages, more inflammation, more scar tissue forming on your retina. Scar tissue contracts. When it contracts, it can detach your retina like pulling wallpaper off a wall. Retinal detachment is a surgical emergency. Even with surgery, vision recovery is limited, especially after 60 when your tissues don't heal as well. Patricia's right retina detached completely during her first laser treatment. The surgeon couldn't save it. Her left eye has partial vision, enough to navigate her house, not enough to read or drive. I asked her what the blurry episodes felt like. She said, like looking through a smudged window. I'd blink a few times, and it would clear. Write that down. If you're diabetic and your vision blurs, then clears. That's not normal aging. That's a hemorrhage. You have maybe weeks, not months, before permanent damage sets in. The specific fix: see an ophthalmologist, not an optometrist, within 48 hours of any vision change that resolves on its own. Ophthalmologists can do a dilated retinal exam and fluorescent angiography to see leaking vessels. Optometrists can't perform the interventions you might need. Early laser photocoagulation can seal leaking vessels before they cause vitreous hemorrhage. The success rate is over 90% if caught early. After a major bleed, it drops to 40%. Time is retinal tissue. The fifth and final thing you must stop: thinking that good blood sugar control means you're safe from eye damage. This is the cruelest myth in diabetes care. I've seen patients with A1Cs under 7 for years still develop severe retinopathy. Why? Because duration matters more than control once you pass a certain threshold. If you've been diabetic for more than 15 years, the clock has already been ticking on your retinal blood vessels. Every year of exposure to elevated glucose, even well-controlled glucose, causes cumulative damage. The Diabetes Control and Complications Trial, one of the longest studies on diabetic complications, found that people who had diabetes for 20 years had a 68% chance of developing some form of retinopathy, regardless of their current A1C. 68%. Tight control slows progression. It doesn't stop it. It doesn't reverse damage already done. I had a patient, Robert, with an A1C of 6, 5 for 8 straight years. He was proud of it. Showed me his logs like report cards. Then he started seeing floaters, dark spots drifting across his vision. He ignored them because his blood sugar was perfect. Those floaters were red blood cells from microhemorrhages. By the time he came in, he had macular edema, swelling in the central part of his retina, responsible for sharp vision. The mechanism is related to something called vascular endothelial growth factor, or VEGF. Even with good blood sugar control, years of diabetes cause your retinal cells to become oxygen-starved. They release VEGF to grow new blood vessels. Sounds helpful? It's not. These new vessels are fragile, disorganized, and leaky. They're called neovascularization, and they're the hallmark of proliferative retinopathy. They bleed easily. They scar easily. They pull on your retina. Robert needed monthly injections of anti-VEGF medication directly into his eyeball for 18 months. He still has distorted central vision. Reading is hard. Faces look warped. The specific fix: if you've been diabetic for more than 10 years, you need a dilated eye exam every 6 months, not yearly. Medicare and most insurance cover this. Your ophthalmologist should be taking retinal photographs and measuring your retinal thickness with optical coherence tomography. These tests catch changes before you have symptoms. If neovascularization is detected early, laser treatment can prevent bleeding. If macular edema is caught early, anti-VEGF injections are more effective. Starting tonight, mark your calendar for eye exams the way you mark birthdays, non-negotiable. I need to tell you something I've never told anyone outside an operating room. There's a moment during open heart surgery where I hold the heart in my hands while we prepare to connect the bypass machine. The heart is still beating. You can feel every contraction, every squeeze, the muscle fibers bunching and relaxing against your palms. It's warm. It's wet. It's alive in a way that watching it on a monitor can never capture. It's working so hard to keep that person alive, pushing blood through miles of vessels, feeding every cell, every organ, every tissue. It never stops. It never takes a day off. Your heart has been beating for you since before you were born, every single minute, without fail. Before you took your first breath, before you said your first word, before you knew your own name, your heart was working. That's the image I think of when I see diabetic patients lose their vision. Not because of the heart itself, but because of what it represents. Dedication, relentless function, unearned loyalty. Your body has been fighting for you your entire life, and these 5 mistakes are friendly fire. They're not deliberate. They're not malicious. They're born from bad advice, incomplete information, and a medical system that treats numbers on a chart instead of blood vessels in a human being. I've stood in waiting rooms and told families their loved one didn't make it through surgery. I've watched spouses collapse. I've held the hands of children who just became orphans. That weight never leaves you. But there's a different kind of weight when I tell someone they'll never see again, especially when it was preventable. The surgery deaths, as devastating as they are, often involve disease that was beyond anyone's control. Advanced cancer, massive heart attacks, genetic defects. But vision loss from diabetic mistakes, that's different. That's someone following instructions that were incomplete or wrong. That's someone trusting a system that didn't take the time to explain why the instructions mattered. Margaret sat in my office after her 3rd laser surgery, her daughter holding her hand, tears running down both their faces, and said, "I did everything they told me to do." She wasn't wrong. She was let down by a system that prioritizes A1C targets over education, by doctors who don't have time to explain mechanisms, by a culture that treats supplements like candy, by insurance companies that won't pay for ophthalmology visits until damage is already done. Margaret's vision stabilized at 2200 in her right eye, legally blind, and no light perception in her left. But here's the part that keeps me going. Her daughter, Jennifer, is diabetic too. Type 2, diagnosed at 49, now 56. She heard Margaret's story from the hospital room. She watched her mother try to identify her by voice because she couldn't see her face. She made a decision that day. Jennifer's A1C was 8, 9 when Margaret went blind. Her endocrinologist wanted it under 7 within 3 months. Jennifer said no. She showed him Margaret's hospital records. She asked him to design a slower plan. Together, they mapped out a 9-month reduction strategy. Month 1, adjust diet, add metformin, target 8, 5. Month 3, add basal insulin, target 8, 0. Month 6, optimize insulin doses, target 7, 5. Month 9, fine-tune to 7, 1. She hit every target. Her retinas had time to adapt. She stopped taking the vitamin E her mother had given her. She reduced her fish oil from 3,000 milliliters to 1,000 milliliters under her doctor's supervision. She kept her baby aspirin because her cardiologist explained the cardiac benefit outweighed the eye risk at that low dose, but she wasn't stacking blood thinners anymore. She saw an ophthalmologist within a week of noticing a single floater and caught early background retinopathy, the first stage before vision-threatening complications develop. Laser treatment sealed the problem areas. 3 sessions, each taking about 20 minutes, targeting leaking microaneurysms before they could hemorrhage. 2 years later, her vision is 20/25 in both eyes. She can read street signs. She can read her grandkids' text messages without squinting. She can drive at night. She can see her kids' faces across the dinner table. Margaret told me during a follow-up visit, I lost my sight so Jennifer could keep hers. If my story stops even one person from making the same mistakes, then maybe this wasn't for nothing. Then she said something that broke me. Something I think about every time I see a diabetic patient now. I wish someone had told me that going slower was okay. I thought I was running out of time. Every doctor visit felt like a scolding about my A1C. I thought if I didn't get it down fast, I'd have a heart attack or stroke. Turns out I had more time than I thought. I just needed to use it right. I needed someone to tell me that my eyes needed the same gradual adjustment my body needed, that crashing my numbers to make my doctor happy would cost me something I couldn't get back. Let me give you the 5 things in order, numbered, so you can write them down or share them with someone you love. 1. Never drop your A1C by more than 1 point in 3 months without ophthalmology monitoring. Slow and steady protects your retinas. 2. Don't take extra insulin to correct bedtime highs without understanding the cause. Glycemic variability kills vision faster than sustained elevation. 3. If you're taking aspirin for your heart, do not add high-dose vitamin E or fish oil above 1,000 milliliters without your doctor's explicit approval. Multiple blood thinners turn small eye bleeds into vision-ending hemorrhages. 4. Any vision change that comes and goes is a medical emergency. See an ophthalmologist within 48 hours. Blurry episodes are hemorrhages, not tired eyes. 5. If you've been diabetic for more than 10 years, get dilated eye exams every 6 months. even if your blood sugar is perfect. Duration causes damage that control can't erase. Here's what I want you to do right now. In the comments, tell me how long you've been diabetic and when your last dilated eye exam was, not your yearly optometry checkup. A dilated exam by an ophthalmologist with retinal imaging. If it's been more than a year, or if you've never had one, write, "I need to schedule." That accountability might save your vision. If this information could help someone you know, a parent, a friend, someone in your church or community, share this video. They might not watch it today, but when they see a floater or have a blurry morning, they'll remember you sent them something about diabetic eyes. And if you're still here, if you watch this far because you care about keeping your vision or helping someone else keep theirs, subscribe to this channel. We talk about the things your doctors don't have time to explain, the mechanisms behind the advice, the mistakes that seem harmless until they're not. It is never too late to protect what you have left. One last important thing, and I mean this personally, not as a legal disclaimer. I'm a surgeon. I'm not your personal doctor. I don't know your medical history, your current medications, your allergies, or what your most recent labs look like. This information is based on 30 years in operating rooms and clinics, on patterns I've seen repeated across hundreds of patients, on mistakes that keep showing up, on patients who've taught me what the textbooks left out. But you need to make decisions with your actual healthcare team, the people who have your complete chart in front of them, who know your individual risk factors. If something I've said contradicts your doctor's advice, talk to them about it. Ask them to explain the why, the mechanism, the risks and benefits specific to your situation. If they can't or won't, find someone who will. Your vision is too important, too precious, to leave in the hands of someone who doesn't have time to teach you how to protect it. And if you take nothing else from this, take this. Your body has been working for you every single minute without complaint. The least we can do is stop sabotaging it with mistakes we didn't even know we were making.